therapy, a little episode 2 of Differential Diagnosis, a little DDX. I like the primal caveman version of the DDX. A diagnostician, a diagnoser, a diagnosticator. Got my resorting back to episode 1. Probably wondering why I had a little tugboat in my arm, as well as a little airplane off the side of there. Playing around my little model, my Skidoo. My first Bombardier snowmobile right here, a little model. It was back in the day, so I still do a lot of snowmobiling, but where I could take my snowmobile apart, strip the engine down, clean out the jets, clean out the carburetors, do some work on the primary and the secondary clutch, change those guys on out, adjust those, play around with the springs, play around with the helix, play around with the suspension and adjust everything. Today we have, in this world, the old school traditional sense and approach of where I come from with this diagnostician related stuff coming from, again, my father's farms, my grandfather's boat marina and recreational vehicle workshop. Was an interesting place. Boat. My grandfather worked on boats all the time. Inboard, outboard engines, sold pontoon boats. He was also had his license to fly a plane in World War II. Worked on all the engines out on the ships and stuff like that. Today we're confronted with, in the piggyback episode 1, this inability to properly diagnose what someone has, and first and foremost, hey, are they within our scope of practice to treat? Which translates down to, should I be seeing this patient? And the root of the problem, today, we don't have the time or the patience to ask and to facilitate the questions that need to be facilitated so that we can create a story, many stories, to engage with and upon our patients for them to provide us the answers. We instead have all this high-tech, fancy equipment that we run to for imaging, whether it's CT scans, MRIs, radio images, which are X-rays, standard civilian ways of seeing that. We no longer know how to use a reflex hammer. We no longer know how to use a goniometer, which a lot of times isn't a bad thing, but I like to use it in a more functional-like approach. We don't know how to use a tape measure or a yardstick to assess if we're having and seeing sustainable change. We lose out in our ability to properly know and understand as physical therapists today whether or not these patients are within our scope of practice to treat, which is really important because, A, first and foremost, why are they there? Don't waste your time. Don't waste my time. And if you have something outside of my scope of practice, piggybacking again back to what we just talked about, initial evaluation, when I see a patient, hey, you know what, unfortunately, your symptoms, based on where you are in the stage of healing, the mechanism of injury, what makes it better, what makes it worse, what I've hypothesized that you potentially have, when this happened, the chronicity of it, have you had it before, I need to flare you up, meaning I need to irritate the crap out of your symptoms today. I also need to make them better. I need to exacerbate them, make them worse. I need to alleviate them, make them better with movement. As an applied functional scientist, I need to know, an applied functional scientist that is a physical therapist, I need to know better than anybody in the world. There's not a lot of us out there. I need to know better than anybody in the world amongst this group of clinicians. I need to know the intricacies of the entire kinetic chain three-dimensionally. So, as a diagnostician and as a physical therapist, it's all about pathologies, a disease state. is the disease or the pathology that you have within the musculoskeletal and the neuromuscular realm and system of treating, or is that pathology, that pathological state that the patient is in, or that some form of tissue is in, outside of my scope of practice? If I'm starting to now, with regards to the rehab diagnosis, meaning, hey, what is it specifically? What do I have? Do I have a grade 1 or a grade 2 hypomobility of the glenohumeral joint capsule, the shoulder joint capsule, front, back, bottom, anterior, posterior, inferior? Do I have some hypomobility, lack of mobility, and what grade is it in the thoracic spine, or some degeneration in the cervical spine? What level? And is it a true cervical radiculopathy? How about in terms of a nerve lesion? Do I have a grade 2 sprain of the ulnar collateral ligament? Do I have some form of tendinopathy of the supraspinatus or rotator cuff tendon? Is it reactive? Is it disrepair? Is it degenerative? Do I have some form of graded sprain of a knee ligament, ACL, PCL, MCL, or LCL? Do I have some form of tendinopathy? Do I have some form of subchondral, osteochondral deficit, some form of bone bruise at the knee, at the talocrural joint, the ankle? Do I have some form of cartilage or meniscus related injury? Okay, but where's it rooted in? So we oftentimes lose sight of this. We get very, very lazy. We get crimped for time. We have a crap ton of time that goes into the evaluation process. An hour and a half for myself. If you're not getting an hour or an hour and a half or more for a good orthopedic evaluation in terms of hunting down the rehab diagnosis and, more importantly, the root of the problem, your time's getting wasted. You need to understand as a patient that you need to be given the time. Your voice is of great significance because you provide the answer. You also need to know that your clinician is not getting paid most typically to do his notes. All these notes are done on their own dime and their own time, and this is hours a week. It's easy for people to let their guard down and for things to slip through the cracks. People getting treated for weeks and months that have something of great utter significance in regards to a pathology outside of the clinician's scope of practice, where an individual doesn't get better and they're not making gains. And when it comes to that as well, you need to listen to your clinician. You need to, based on the state of condition that you are in and healing and what you've previously dealt with regards to this injury, we get that you have stuff to do, whether it's recreational, occupational responsibilities and stuff that you love doing, but if you're not giving things time to reset, to recalibrate, for a new system to be uploaded and downloaded, just like that of a phone or of a computer where we have hardware updates, you need time for recorrection to take place because your problem didn't come on overnight or in a week or two. This is months, weeks, years of chronic compensation. We're the masters of adapting and compensating. So you need to listen to your clinician, and you need to be very specific with what you're doing with what they've given you at home, so that you're not taking a good thing and making it worse by doing more. So lots of variables to pay attention to, but first and foremost, you will and should be referred out very, very soon if you are presenting with something that is not within the physical therapist's scope of practice. It is very, very easy this day and age that we're in today for things to be missed. Very big red flags by your primary care physician or by an orthopedic surgeon and specialist, because you're in and you're out quick. They're, again, looking at an anatomically based location and spot. They're not experts by any means in movement. Their job is to diagnose disease and perform surgical intervention. Very important that you realize that. So, we've got these different filters. Lots of people oftentimes slip through the cracks. Just because your primary care doc doesn't say you don't have something is not true. There's specialists in different areas that you need to be able to glean from based on the referral of your physical therapist. So there's oftentimes, again, so between the primary care doc and the physical therapist, you have two different sets and waves of people that can really miss things. And I've seen I've seen some really, really poor, some really, really poorly missed things. So with regards to patients, do you feel like you're being treated as if this individual that's treating you is looking at you like you are their mom or dad, grandma, grandpa, brother or sister, or best friend? That's the way that you need to look at this, and that's the way that you need to feel. You need to feel like you've been given the time of day, and you need to continue to question, because it's your right as a patient to be educated, but also to question with regards to this dialogue in the and what makes up your health care. Ask questions, be educated, do your research, do your homework, stay off the internet. There's a lot of junk on the internet. Go get references and referrals from and collaborate with people that you know are going to treat you well. And we're going to dig into this a little bit more. DDX, Differential Diagnosis. A diagnostician is great at listening. They want to know what your injury was, what caused it. Was there a mechanism of injury? What makes it better? What makes it worse? When is it better? When is it worse? There's a lot more that goes into it than these questions. But I've sat several times on the other side of a small little table or in person down in a squat position making eye contact with someone. And in the back of my mind, the wheels cranking away saying, prove to me that you do not have a blood clot, that you don't have or haven't just experienced a TIA, a transient ischemic attack, that you don't have cancer. You have to go about it that way, and you need to go after it hard with regards to reproduction of symptoms and movement. An applied functional scientist, physical therapist will know everything from first hallux, so your big toe, to your little pinky and everything in between, what all that connective tissue, all that fascia, from the muscle bellies down to the tendinous, the ligamentous related structures, and these atlas, these meridian-like highways throughout the body that are made up of joints, which we get motion through arthrokinematics, we get bone motion, osteokinematics of bones moving, we have cartilage, we have a lot of things that make up this body with regards to nerve innervation, arteries, veins, heart, and lungs. We need to be able to know whether these symptoms are within our scope of practice to treat, and if not, the referral out, there should be no pride that's lost in doing so, as we look the patient in the eyes and say, we need to make sure that you are within our scope of practice to treat. I will make you worse by stirring up your symptoms with movement. I will take them away and make them better with movement, and they need to be able to make sense from my perspective and how I'm loading that tissue up, how I'm stabilizing it, and how I'm moving it. If not, I need to refer you to great specialists that I know that are going to help us in this process and help get you better as quickly as we can.